to run down the rest of the day for you. The next part is going to be a workshop, so we're going to do some open discussion with Dr. Gill and everybody in the room here. And then we are going to break for lunch at noon. So I just wanted to also say this whole workshop is to kick off the demonstration project that Unity House and CARES are working on with the Violence Against Women's Act and the Housing Opportunities for People with AIDS. So this is kind of our kickoff event. So I will, after lunch, before we open it back up with Dr. Gill, I'll get in a little bit more in detail to what that demonstration project is and what's going to be coming up. We also are going to be looking to develop a work group task force to develop the screening tool that we're going to use. So we will be asking for volunteers to sign up for that as well. We're hoping to get a good representation of all of the service providers in the room, and we will be meeting 3 times to hopefully get this tool underway. Okay, so we will open it back up now for the workshop part.
As I was putting this together, I was thinking, what we're going to generate today in the future actually would be a good baseline. So first of all, documenting what you're going to do, where you are and where you're going. But even documenting what we are doing now is actually worthwhile. It could be paper, it could be a research project, a descriptive. This is where we are now. The literature on IPV and HIV is evolving. No one's going to, oh, you're terrible, you're not doing a good job, or you're doing a fabulous job. But it's really nice to say what's going on. And you know, if anyone wants to help pull this together, I would be very happy to try and help, because I think it's just descriptive data is helpful. You might find that, you know, I'd hate you to be scooped by California or whatever who say, gee, IPV in California, this is what we're doing. What you're doing is important, but let's find out, because it gives you a baseline to where you want to get. As I presented about IPV and HIV in a variety of clinical specs, I've never had pushback saying, oh, this is junk, I don't believe it, you know, we don't think it's important. Everyone says, yes, we should be doing it, but then they'll give a myriad of reasons why they're not doing it. So actually what you're doing now, and what we're going to talk about, why you're not doing it, or why you are doing it, and how you do it, is good descriptive baseline stuff. It would be of interest to others. And it might hopefully motivate them to improve care for their patients. So, I'm not sure of the demographics of who's here, but how many, I need a denominator, so how many people who kind of describe themselves as more HIV care providers have we got? 1, 2, 3, 4, 5, 6, 7, 8. Okay. Are you all separate, or are you team players with other people in that group who are related in the same clinic? Okay. So, how many actually ask about IPV? 1, 2, 3. So 3 out of 8, 5 don't. Okay. Now, for those who don't, is that because, well, I assume, am I correct, if a patient mentions it, you explore it. Is that a reasonable assumption? Ah, you've been quiet. There's no yes or right, wrong. There's no one judging here. But if you're not asking, is it because you hope that if there's an issue, you'll stumble it from other reasons? Is that a reasonable assumption? Yeah? I think that's what you're saying. Okay. Now, for those who do you ask once? Do you ask repeatedly? Yeah?
I'm a case manager at Albany Med's HIV clinic, and we do assessments on these patients within my caseload, so I ask them every 6 months. That is not for the entire population of the clinic, though.
Yeah, the ones that are in your group. You know, you can't speak for other people, and other people have other priorities, or they may all feel comfort levels. No right or wrong, it's just a no. Okay, so Okay, so we've got 3 out of 8 caregivers ask, and some do it very regularly, and you'll love the data I'm going to show later of what our patients say. And the others currently aren't doing it. So how many housing providers have we got here? Okay, that's about 20. Yeah. So do any of you ask, first of all, do any of you ask about HIV status? What's the percentage? That's about 70%? And some don't, I guess, because well, it may not be relevant, but some don't, is that correct? If you don't ask, put your hand up. So you will ask, okay. I mean, I can see how you may or may not, there's no right or wrong. Now, how many here are IPV? 5. Okay. 6, 7, 8, 9. Okay. Now, do you ask about HIV? Okay. And then you gather where I'm going. All the people who've put their hands up about things. We're going to explore a little bit about why you do or don't do something, because what are the barriers? Because the evidence is pretty compelling that we should be asking about HIV in housing, we should ask about IPV in housing. If you have HIV, we should ask about HIV in housing. You know, we need to explore what are the barriers that you're not doing it. And it may be legit, like you have too many other things to do. And sometimes my personal belief is we do a whole lot of things that are not really that productive. And my staff, I keep changing everything we do because you find there's a low yield on asking this question. Like an example of that, we've got we just presented at a big retrovirus meeting, the epidemic of syphilis we've got going on in the HIV population. And we ask about, are you having sex and is it safe? Every clinic visit. And why? They're all having sex. They're telling us they're not having sex. They're catching syphilis. So I'm wasting my staff's time asking that question, which is why I'm going to reintroduce. You know, I'll ask him about IPV at every clinic visit because I think the yield on my staff's time is higher. And that's where I'm kind of, you may need to reprofile what you're doing a little bit to make the yield higher on improving patient health. And you know, IPV looks to me 33% in HIV population, actually a good use of my staff's time. So we've got roughly 3 out of 8 of the HIV crowd ask about IPV. We've got many of the housing providers ask about HIV. Of the housing providers, how many you ask about IPV? Do any not, or is that? No? So that's all part of your routine intake. Okay, so I think we've got a little bit of a baseline there. So, let's go with the HIV providers. When you ask about IPV, what's been your experience? Can you give me some description? Is it good? Is it bad? Is it's not worthwhile doing? Or I wish I hadn't got to do it, but because some administrator says I've got to do it, and there's a tip-down box on my screen. Yeah.
Oh, well, I'm sorry. I had two thoughts, but we do it at every visit. I do it at every visit. I'm the substance use specialist in the HIV clinic. So obviously the IPV is directly related to a patient's ability to stay abstinent, because if they're experiencing that, using chemical substances is usually one of the ways they medicate. What I'm thinking as we're here today is that because I have several patients that are experiencing IPV, I'm just thinking that what we need at our clinic is a support group, because though I can talk to them about it and really talk from a professional point of view to someone experiencing it, that if we had a support group in our clinic and we could bring them together, and that's men and women, because obviously it's not gender biased, that it might be a way for them to be empowered, because most of them are coming out of abuse, and the IPV is an extension of what is normal for them.
So you see it as part of routine care.
Yeah.
And it's generally, have you had any negative problems? Like inadequate resources to refer to?
No, I think our clinic is all-inclusive. We have medical providers, psychiatrists, mental health staff, substance abuse specialists,
You're into
case managers,
comprehensive.
so we're doing everything, as well as support groups, but we do not have one specifically for our patients that fall under the IPV category.
Okay, how about the others? What's your experience when you actually screen?
Well, the program that I run is specifically for people living with AIDS and HIV. So that's one of the main criteria for the housing program itself. On the flip side of that, what I do when I have a referral or a resident come in and say, I do an assessment to determine where they are in terms of drug use or domestic violence in the home or outside of the home, if there was any experiences with domestic violence. It's hard to say intimate partner violence because it's not always with an intimate partner. You know, it's those uncles and aunts and cousins that started the abuse. So this is both for males and females within the program. I think our biggest issue with this is having the resources that we need. I mean, I do know a few people at Unity House, but having, and Equinox as well, but having the resources that we need to treat those patients or those clients who have experienced domestic violence or intimate partner violence, that can help them get to a place where they can talk about it, understand how that correlates with their substance abuse and how they got to be HIV positive from the beginning, so that they can start to heal from those things, so that they'll take their medications, so that they'll be more open, so that they'll be more aware of where they are and take them to the next level. So screening is something that a lot of times when our clients come in, we already know for some, because we get referrals from the DP. But doing an assessment outside of what we see for somebody who's not coming from the DP is something that we always do, just to gauge where the person is so we can treat a person holistically.
Have you had any negative feedback from us?
Not so much negative feedback, but a lot of their reluctance to actually talk about it. But because these are clients that I see on a regular basis and interact with on a regular basis, at some point during our conversations when I meet with them, we start to talk about it and they start to open up. And then I can suggest to them, hey, how about doing some one-on-one or group treatment to deal with those issues?
So you send them on to.
And I find them to be receptive if they really need it. If it's really a barrier, and I find barriers with those persons who have engaged in long-term substance abuse.
You skirted around, I think you were trying to say, we got trust.
When they trust me, absolutely.
And because this, what I'm
Absolutely.
going to present this
Because it is
afternoon, it's
trust.
all about trust.
It is.
Because, you know, these are very dark, sinister parts of people's lives.
Absolutely.
And you don't cough it up to a stranger, which is why I think HIV is really good at finding it, because you have trust. You see someone month after month.
As a part of an assessment, they'll say, yes, it's happened, but they won't elaborate. So you don't know where they are until after you gain their trust. And then you can suggest if there's a need for counseling.
For the non-HIV care providers, the HIV crowd, we're really obsessive compulsive friends with adaptations to
Yes.
skills every day. Just in case you wonder.
Yes, we are.
You know, we're really got a character we piss on them. Okay, now there's someone else another HIV program that screens? No? Yes.
One of
Oh,
the
you
main-
screen every 3. You're fabulous, that's good.
But the patients that aren't on my specialized caseload will be screened every year. And one of the main questions we ask them is, do you feel safe at home
Yeah.
versus do you have domestic violence at home? And so some of the experience with that question, patients are like, what do you mean? Like, I live in a safe neighborhood, everything's fine there. So they may,
We'll laugh because we do.
that's not what I'm asking for. But at the same time, it also allows that conversation to, do you feel safe? Do I feel safe at home? Well, maybe, but do I feel safe about my kids going outside of my home? So that our question, which is intention to talk about HIV, also brings up other concerns that people may have about their families and their living situations, not necessarily intimate partner violence, but violence in their communities as well.
Now, and when you find it, you've got the ability to refer out, or you do it in-house.
If someone's experiencing violence in home, I refer them out.
And the structures are out there?
Yes.
Reasonably good. Now, and no really negative, generally you're kind of supportive that you're accomplishing something by asking. Well, I think what everyone's saying, who does. So, okay, let's, so for those who don't, because I think there were 8, there are a few that kind of programs that don't ask. What is it, can you give me a little bit of a context of why have you not got leadership? Or is no one's giving you the tools? Or what are the gaps we need to fill in from today and the next few months to kind of address what most people think is where we should be? Yep.
I'm very new to my program, and ours is kind of ancillary. I work at an organization, the Damien Center in Albany, which works with patients with HIV. I'm in the PEP program, so I have an interesting way of interacting with them, and I'm just kind of learning how I can be trusted to ask those questions and lead them. So that's kind of why I'm here.
Okay. Okay. Is there anyone else who's not doing it? Because otherwise it sounds as if you're doing really, at least many of your HIV care programs are at least thinking about this or implementing to some extent. And if you've got a case manager who's really into it, you're doing it every 6 months, which is great. Okay, so what about the housing group? What are they asked? What tools do you use to ask? Can you tell me, what you ask every time they're readmitted, or they get the housing stable, and then they disappear on you, and then they come back? You ask every time? And how do you ask, and what do you ask them? The silence is you scared. Yeah.
We ask upon intake, we do permanent housing for single females, so they can stay however long they need the housing. And we ask upon intake. We found we weren't getting any yeses. People weren't identifying. I mean, we knew there must be some kind of population we were getting, so we deal with homeless women. So we changed the structure of the question to ask, like, do you know your HIV status? And then we also explain that we have certain housing programs in our community that are specific to that population, and that's why we're asking, because it may be a benefit to them. So we still don't get, I would say we still don't get many yeses in our program. People aren't really identifying. I don't know if they don't see the worth, they don't see how they're related, they don't know why they would tell us. But again, it's upon that first meeting, so why would they really trust us?
It comes back to,
Yeah.
this lady's got trust. You know, they see you and this is something really dark. They don't want to tell you. They don't trust you yet. But you keep asking, you show integrity and safety, and you may get that. Yes?
What has worked for me, actually the event has recently just happened. The young lady disclosed to me asked about our housing in the past, a few years, and she just disclosed to me up front as a DV situation. And then to really work with someone, then you see the person who's inflicting that upon them in the same environment, kind of sort of. It's kind of like, well, we're gonna get you in a safe space. We're gonna get you out of this situation. We're moving expeditiously behind the scenes, you know, because they're like, oh, I gotta get out, coming from a shelter, homeless situation. So I like to keep an open-ended question and make them feel as comfortable as I can. Sometimes that just rolls out as far as when we get into housing. This is what's been going on in the past. This hasn't worked. I've been through these different programs, but this is, you know, so they usually pretty much open up. You know, definitely when I engage with them.
Excuse me, could you say where you're from when you answer?
Oh, I'm from the Albany Damon Center.
Oh, okay,
Housing
thanks.
Guru.
Thanks, and,
Well, the YWCA in Schenectady.
oh, okay, thanks. And also, for the wives, are you asking about both HIV and IPV?
We are a domestic violence agency,
Oh,
kind of
okay.
an umbrella,
So you
but we offer.
assume that.
Yeah, I mean,
Okay.
they don't necessarily have to have experienced domestic violence to get housing with us, but we offer counseling, emergency shelter, advocacy, and the legal department. So we have a lot of DV services, so we do ask that when they come to housing as well.
Okay, thank you. Thank you.
Just to piggyback off of, I'm sorry, the name, but, yes.
Lauren.
One of the things that I've found, because I've been doing housing for HIV for a very long time, is that one of the reasons why people don't disclose is because they're still afraid of the stigma attached to HIV. Working in this community, I've heard terms used to describe HIV as dirty blood. So the stigma that's attached to the HIV, even though there has been so many strides to eradicate the HIV or to just make people generally more healthy, people are still afraid to disclose that they are HIV. So irregardless of the fact that you say, well, if you disclose there are certain housing opportunities that you have outside of, you know, what you might get through DV or through mental health or anything else, people don't want to say, I'm HIV positive, because they don't want people to look at them differently. And so the stigma for HIV, even though the disease has been so profoundly, you know, there's been such a big turnaround, people are still afraid of the stigma of it, because people still are very ignorant about what the HIV disease is and how it's transmitted. And so, you know, you still have that stigma attached. So what I found in housing is people won't disclose because they don't want that to happen to them. They don't want to become sick.
Part of the
After all
systemic, isn't
these
it?
years. Yes.
Stigma.
Yes, absolutely. I'm the director for Support Ministries. It's a housing program, transitional and permanent housing for people with AIDS and HIV. Yes, it is.
As an aside to make the HIV care providers weak, I have a
Yes.
lady who
Absolutely.
keeps finding a new guy, and she's worried that he'll see her HIV drugs. So if she finds a new guy and stops the pills, and he doesn't know that she's got HIV. We all have the same problems. You know,
I share with everybody, I travel around the whole state talking about HIV for New York State Department of Health, reducing stigma. I talk in the pulpits and the churches, and a lot of from IHOP in the stores. I talk to everybody about HIV, and it's a lot of communities are still stuck in the 80s as far as the mental visual of what's going on, and it's being generationally embedded in a lot of younger folks. So you know, so New York State has an aggressive team. We have there's about 35 of us who are positive throughout the state. That goes around the high schools, colleges, universities, wherever there's a body or a barbershop, a beauty salon, we're out there reducing stigma. So that's always work at play. I'm always available to speak to any platform. I'm speaking at Colony High tomorrow.
Did you bring cards?
Huh?
Did you bring cards?
Yes, I have. But stigma is a big issue as it pertains to housing, and once you become positive, your companionship is the biggest thing with anybody who's HIV positive, if they're born with it or not. But if it's companionship, and that leads into all these other categories because they're out there trying to find that special someone, and you know, if they're easily to be influenced by a committed relationship, all they want is companionship. You know, so they'll do anything. They have their medications, stay off their medications. I mean, they go drastic measures to get companionship. And, you know, the DV, they'll sit it out. They'll ride it all the way through just to have that committed relationship. And we're seeing that too, so it's a big issue.
So, what's the promotional message then that you need to use to diminish the stigma?
Normalizing the conversation.
Yeah, in Canada, we've got two things that I promote, and every time I talk to the media is, first of all the insurance companies in North America have now made HIV insurable. That's contingent on you taking your drugs. And that is a really, you're now insurable. They think you're insurable, known risk. You take your drugs, you can do well. And also, in Canada, we had a Supreme Court decision. If you're on treatment with an undetectable viral load, you are unlikely to be deemed criminally responsible for having unprotected sex. Now, that's actually really good from my point of view, getting the stigma down and saying, look, our highest court of law said, if you're on treatment, you're not going to infect anyone. So why aren't you taking the treatment? You want to set up criminal liability? Well, stop your treatment. Then you might get locked up or charged.
Right.
And that's really compelling to keep people. Say the stigma's not, if you're on treatment, you're not infectious, you're insurable.
And to piggyback on what you're saying, a lot of this, there are 38 states that have the 80s regulations in there, like our Vice President, Mike Pence. He's a notorious, for HIV, he defunded HIV funding in his state 3 times. And he's been in violations of public health law with HIV. Because, you know, so states like his, you know, they're out there. And people are migrating to New York State. And they have dual residencies to access care or even including housing, you know, so. But yes, my job, what I do for the Department of Health is go out there and normalize the conversation. How can we normalize this conversation? And that's what, you know.
So promote the message, you're not infectious and you're insurable when you're engaged in care. And that will hopefully impact in any other things that we think, the stigma. Because stigma's limiting a whole lot of issues. Okay. So when you screen the people, anyone in the room who screens for IPV, we probably need to get an inventory of what tools you use. I'm not sure they have to be a precise tool, and the one we're thinking of moving for repeat evaluations, are you safe in your current home environment? Do you have any specific tools, or is it an ad hoc, or is it a general kind of, are you safe? What do people use? Come on, everyone who said they screen, what tool do they use?
To screen for IPV.
Yeah, for IPV. Yep.
There's a question on the assessment that says, does the patient feel safe at home?
Okay,
Yeah.
so it's a very general catch-all, pretty good actually. I mean, you don't have to have precise definitions. I mean, we got into these 7 domains. What do other people use?
Another general question is, are you experiencing domestic violence, or do you have a history of it?
Okay, so specific for mentions domestic violence. Do you think we need any, I mean, you know, we have the tool we have, but do you think we need anything better than that? I mean, because I'm not sure that you need the intense screen we do, or whether that is actually a good introduction.
I think one of the issues is that because they normalize it, if it's not happening every day, if it's periodic, you know, episodic with somebody that's on treating mental health, they kind of ride through that storm, but they don't necessarily see it as domestic violence. So I think that's really an issue that, I mean, although we talk about it at every visit, and I see my patients more regularly, so it's not, I don't think it's getting missed, but I do think the issue with our HIV population is that they are, and I think you said it, there's such a need for love and acceptance that they're willing to accept the episodic domestic violence because the bigger picture is that they are in a relationship and they feel good about that. And that's sad. I always talk to them about their value and their worth as a way to counter the fact that they are allowing it to happen at any time.
Yep.
And one of the biggest things for someone who is positive, who's seeking relationship, is we're always having dialogue and discussions about disclosures. How, when, who, and where to disclose, almost like before you propose. Where do you want to propose at a game or what? I mean, it's like, so that's one of the biggest questions too. I discussed with a lot of other positive individuals is where can I disclose? Who would I disclose to? Do I really need to disclose? I mean, I know some people who just tell everybody that they're positive, and they get good and bad results from the public. You know, like, oh, I want to beat you up, and some people, oh, I just love you. You know, but they don't internalizing it. They still don't know how to receive the good and the bad. You know, from their disclosing, they just tell everybody. You know, it's cool, but are you educating people while you're doing it and stuff like that? So, yeah, I just thought I'd share that.
So that's the age. What about the housing people who ask about IPV or domestic violence? What tool do you use? Yeah.
Since ours is largely a DV overlap program, it's a normal course of dialogue for us, but since we're also permanent long-term housing, it's an ongoing conversation if somebody gets into a new relationship to check in. Does it feel healthy?
So it's
to
a
you?
sort of free text.
Yeah, it's
But the
ongoing.
theme is you like to know.
Yeah, but also asking things like, do you feel like this is a healthy relationship? Do you feel safe? Do you feel comfortable talking about whatever you want to talk about? Do you feel supported? So it's not just, it's expanding that window beyond it, just the physical violence piece that's assumed in the definition, that could be sexual abuse, could be economic abuse, could be emotional abuse, and just keeping that door open to talk about. And we bring it up in friendships too, just we've got a lot of women living together and some unhealthy friendships can form, and so talking about push and pull in that dynamic and opening eyes to what feels good and what you should and you don't have to accept in relationships in general.
Okay. Other programs, other housing.
Are you from the Alliance?
Yes, ma'am.
And what about HIV? What tool are you using to ask about HIV?
We ask at the initial intake interview if they've had a recent test and if they were able to get the results, if they know what their status is.
Okay.
And then we leave the disclosure up to them. Like Lauren was saying, we suggest that there might be some other programs that can help if they do a positive status, but we're not required to know. And again, it's something with ongoing dialogue, like, because we're together all the time, when are you going to the doctor, how you feeling, how you doing, stuff like that, and then we can choose to disclose or not.
Okay, thanks.
Okay, other housing programs, how do you ask? Yep.
We have a basic checkbox on our intake. We're an HIV housing provider. We also provide mental health housing. So we ask, are you safe at home, experiencing domestic violence, and then we revisit at reassessment. But I feel we absolutely need a better screening tool because we're missing the nuances of IPV. I mean, I think people have sometimes that cookie cutter view of what domestic violence looks like, and I don't think we're capturing the emotional abuse or physical restriction and the other aspects of that. So that's what, hoping that you guys will help us develop a screening tool.
Most of this is you ask about as an adult. I mean, we've got data where we've looked at people who experienced abuse as a child, but not as an adult. And actually, these individuals, despite sometimes being in counseling, have horrible legacy damage. And we can see that although as an adult they haven't had anything really bad happen to them, that has injured their adherence, their psychiatric use, their social work, their career progression. And often I think that's something that what you're describing you probably might want to build in, even as an adult, because don't just look as an adult, because sometimes there's this horrible history. Okay, other housing. Yes, sorry.
Well, I just thought I think that it is important. If we ask the question, I think that the patient is thinking about getting hit, but it is emotional, verbal, sexual. I mean, there's so many aspects of it, and I don't think we're capturing that, because, again, that's just their normal experience. If somebody's not hitting or pushing, then they may not view it as IPV, but in fact it is.
I didn't when I started, I thought it was sex and violence. Yes.
So I work for a domestic violence agency, and in one of my previous positions, I worked in family court helping victims get orders of protection. And I would have a lot of people who would come in and they would say, I don't know if I qualify for your services because he's never actually hit me. So so then I have to have the whole conversation about, well, if there's other things going on, if there's emotional, psychological, whatever else, then as a power and control, then you certainly do qualify. But I think the fact that, we get asked, do I even qualify to get help from you, just really goes to show that they're really just envisioning, if I'm not getting punched in the face or shoved down the stairs, maybe I don't count,
So we need the education on those domains that are out there. I agree. Yes?
I feel like, to your point, that like, when I ask, do you feel safe at home? I feel an obligation that I want a screening tool that it elaborates on emotional, financial, sexual abuse, because if they hear it from me at the doctor's office that all these different aspects can be part of it, when they go see you for court, that they will already have that seed planted in their mind to make those services easier.
Right.
And then if they have a friend or a family member who, oh, hey, yeah, so I learned like financial abuse is a bad thing, is an abuse, and it seems like you're going through that, friend. Like if we can plant those seeds with our patients or our consumers at our location, it could permeate through their community.
And I think that can work the other way too, because if, when I look at the New York State list of family offenses, things like harassment, financial abuse, they are family offenses under New York State law. So I think to say, if it's part of the law that this is abuse, I think that's very validating to victims, and I think it helps them to realize that what they're going through does count,
So I think what we're hearing is widespread definition, dissemination of the definitions that are out there, and then a tool that would be appropriate for wherever you work that should have some consistency, so that when you refer to someone or they refer back to you, you're talking the same language. Yes?
We work for an emergency homeless shelter for mothers and children.
Okay.
And the assessment tool that we use comes from the Homeless Management Information Services database. So it's very plain vanilla.
Generic.
Very generic. And so we ask about history. We do the assessment only on the moms, and we don't ask about the kids.
Yes.